This seminar is split into two parts to make it easier to digest. Part 1 includes nursing assessment and pathway, surgical options including the operations and balloon placement, and an anaesthetic overview. Part 2 includes ward care and discharge, dietetic support, psychology support, research opportunities, and how to opt in. We recommend watching both parts to get the full benefit.
Welcome to South Tyneside and Sunderland NHS Foundation Trust's Bariatric Surgery team. I'm Professor Kamal Mahawar. I'm a consultant general and bariatric surgeon of the Trust and have been in the role since April 2011. I'm also the lead for the service. You've been referred to us for bariatric or weight loss surgery, and the purpose of this seminar is to explain to you what your journey would look like within our service, surgical options available to you, and their risks, and also how you can use the surgery to obtain maximum benefit. The whole team, Ms. Masbai in particular, have put in a lot of effort in preparing this seminar. I really hope you find it useful. Thank you.
Hello, I'm Lisa, one of the bariatric specialist nurses here at South Tyneside and Sunderland NHS Foundation Trust. As part of the bariatric team, my job is to support you through your whole journey, from your first assessment through the team process, surgery and long-term follow-up and support. When you are referred to our service, your journey starts with an appointment with one of the bariatric specialist nurses. This first meeting is really important. It helps us get to know you and your health background. We will talk about your medical history, mental health, and a bit about your daily life. We'll also go through any weight loss methods you've tried before, what medications you take, and how your weight has affected your health. It's also a chance for you to ask questions and find out what to expect from the service. At this stage, you'll only see the specialist nurse. You'll meet the rest of the team later on. After your first appointment, your details are discussed at our team meeting. We have a multidisciplinary team, MDT. This includes the surgeon, dietitian, psychologist, and one of our medical doctors who specialises in diabetes and metabolic health. The MDT has access to other clinicians as needed. Together we look at how ready you are and how safe it is for you to move forward with the next step. It's a shared decision that always puts you at the centre. After the MDT, you are either accepted into our bariatric service or discharged if surgery isn't the right step yet for you. If you are accepted, you'll start what's called Tier 3. This is a programme where you learn about healthy eating, get support for your well-being, and have time to learn and practice the changes that will help you long term. We often say you only get one chance at bariatric surgery, so it needs to work for life. If you are committing to bariatric surgery, you are committing to lifelong change, a commitment to living well and making your health top priority. The commitment really starts here with our team guiding you. There are now some new weight loss medications available. They can work very well for some people and can help improve health and weight in the short or immediate term. It is important to note that bariatric surgery may not be an option if your BMI decreases significantly while on these medications. This will be a key decision point between you and your surgeon. For people living with more severe or complex obesity, surgery is still the most effective long-term treatment. It's usually recommended for those with a BMI of around 40 or higher, or for those with a BMI of 35 to 40 with weight-related health problems that could improve with surgery. Once surgery is suggested by the MDT, you meet your surgeon and be given clear information about what to expect before, during and after your operation. Our team work closely to make sure everything runs smoothly, from pre-op checks to recovery and discharge home. We'll support you throughout. Soon after you go home, we'll call you for your first checkup. We'll ask how you're feeling and make sure you're drinking enough fluids. At around 6 weeks, you'll have another telephone appointment with us. We'll talk about how your diet is going, your energy levels, and your supplements. This early follow-up helps us make sure you're healing well and staying on track. We'll keep in touch with you for up to 2 years after surgery. This will involve regular follow-ups with our team. At each appointment, you will be given support. You'll also have access to our psychology teams if you need more help. Ongoing support is key. It helps you stay motivated, keep a healthy lifestyle, and feel confident in the changes you've made. Our goal is to help you achieve safe, steady, and lasting weight loss, but more importantly, to improve your overall health and quality of life. Every step of the way, you'll have the support, care, and guidance you need to succeed.
Hello, my name is Will Carr and I'm a bariatric and upper GI surgeon based at South Tyneside and Sunderland Foundation Trust, and I will be talking about the Roux Gastric Bypass. Like all bariatric operations, this is done by keyhole. Just like the sleeve and the One-Anastomosis Gastric Bypass, we place 5 ports to allow the entry of keyhole instruments and a camera to perform the operations. For the Roux Gastric Bypass, we start by creating a very small pouch at the top of your stomach. This becomes the new stomach that will hold food, so you feel full much quicker. The rest of the stomach stays in the body, but food no longer travels into it. As nothing is removed, the bypass is reversible. Next, a loop of small bowel is brought up and joined to this pouch. This is the first join, through which food will now enter the intestine directly. Further down the bowel, we make a second join, reconnecting the bypassed intestine so that food and digestive juices can mix again. Food now goes from the pouch straight into the bowel, missing the majority of the stomach and the very top of the intestine. This helps you feel full sooner and reduces how many calories are absorbed. Because bile and acid are diverted from the gullet, it's also an effective treatment for acid reflux disease. The Roux gastric bypass is excellent for weight loss and can have a very strong effect on diabetes and metabolic health. It's a more powerful operation than a sleeve. Some people even come off diabetes medication very quickly. It reduces appetite and can improve mobility, sleep, fertility, and energy levels. Many people report a major improvement in quality of life. It's also an excellent operation for treating acid reflux disease. We usually avoid a bypass in smokers and in patients with inflammatory bowel diseases such as Crohn's disease or severe IBS. We also avoid it in patients who take medications affected by malabsorption and in some people who have had many previous abdominal operations. That's because the anatomy is more complex and complications become more likely. As with any surgery, there are general risks of bleeding, infection, blood clots, kidney issues, or the need to convert to open surgery. Common recovery issues can include things like nausea or vomiting, bruising, bleeding, or infections affecting the wounds, urinary tract or chest. In rare cases, sepsis can develop. Some people experience temporary difficulty drinking or swallowing right after surgery. This is called dysphagia, and it usually improves with the support from our team. There is also a low risk of injury to the bowel, stomach or other organs, or of the bowel or stomach becoming blocked. These can be serious complications that we aim to recognise early and can require further surgery. The most serious is an anastomotic leak, which means the join between the stomach pouch and the bowel doesn't heal properly. This risk is less than 1 in 150, but it requires urgent treatment and can involve another operation. Another risk is an internal hernia. This happens in about 1 in 50 people. This occurs when a piece of bowel gets trapped or twisted inside the abdomen, causing blockage. It usually needs surgery to fix. The joint can also narrow over time. This is called stenosis. There's a risk of ulcers happening at the joint, which can bleed or burst and need further treatment. And this is especially the case if you smoke or take non-steroidal medications, such as ibuprofen. It can cause vomiting or difficulty swallowing and may require stretching or treatment. Dumping syndrome is quite common after bypass. Patients may feel dizzy, sweaty, or have diarrhea after eating certain foods, especially sugary ones. It's manageable with dietary changes, but it's important to understand it beforehand. Around 1 in 3 people may notice frequent or loose bowel movements, and because food bypasses part of the bowel, nutritional deficiencies are a lifelong concern, meaning blood tests and vitamins are essential forever. Immediately after surgery, your hair or face may have a slight blue tint. This is normal. It's from a blue dye we use during surgery to check the joint for leaks. It fades quickly and is nothing to worry about. We do this blue dye test for other surgeries that we perform, such as the One-Anastomosis Gastric Bypass and the Sleeve Gastrectomy. Occasionally, we start the operation but can't complete any bariatric procedure. This usually happens if the liver is too large or if there are unexpected findings such as scar tissue. Every patient will need vitamins and mineral supplements for life and regular blood tests. Your GP will be informed about this. You will also receive blood thinning injections for 15 days, medicine for gallstone prevention for 6 months, and an antacid such as lansoprazole to protect the joint between the stomach and bowel. Most people go home the day after surgery. Loose skin is to be expected after dramatic weight loss. Unfortunately, plastic surgery is not funded on the NHS to get rid of the loose skin, and we do not perform this kind of surgery. Surgery is not the finishing line, it's the starting line. The operation gives you a powerful tool, but success depends on the lifestyle you build around it. Our multidisciplinary team is here to help you every step of the way. You will never do this journey alone, but it's important to understand that long-term commitment makes all the difference.
Hello, my name's Neil Jennings. I'm a general and bariatric consultant surgeon working at South Tyneside and Sunderland Hospital. I'm here to talk about sleeve gastrectomy, a type of weight loss procedure. This is currently the most common weight loss operation. We remove the outer part of the stomach and create a smaller, banana-shaped stomach. This helps you feel more full and changes some of the hunger hormones in the body, meaning you feel less hungry as well. It can lead to very good long-term weight loss and improvements in diabetes, blood pressure, mobility and overall health. Patients often say they feel fuller with much smaller meals and quite early on. Because hunger hormones change, many feel less controlled by food, which can be a major relief. We avoid this operation if someone has severe acid reflux, Barrett's esophagus, significant problems with their food pipe muscles, or a large hiatus hernia. In those cases, the sleeve can actually make symptoms worse, so another operation may be safer. As with any operation, there are general risks such as bleeding, infection, blood clots, kidney problems, or the need to convert to open surgery instead of a keyhole operation. The risk of death is very low, it's less than 2 in every 500 operations. There are some specific risks to the sleeve gastrectomy itself. One rare but serious risk is a staple line leak, which happens in around 2 in 100 patients. This means the stomach doesn't heal properly where it was cut and stapled together. It can cause infection and often needs another operation and a long time without eating to allow it to heal. There's also a risk of bleeding from the staple line, which happens in around 1 in 100 people. Sometimes this needs a blood transfusion or further intervention. Acid reflux is very common after this operation. Between 5 and 12 in every 100 will experience heartburn after surgery. If you already have reflux, this might make it worse. There's also a small risk of narrowing of the new stomach tube. This happens in less than 1 in 100 people, but it may cause vomiting or a blockage. Treatment may be needed to widen it. Around 1 in 10 people may not lose as much weight as they had hoped. And like all bariatric surgery, there is a lifelong risk of nutritional deficiencies. That's why we closely monitor blood tests and vitamins forever after bariatric surgery.
Hello, my name is Aya Musbahi and I am a bariatric and upper GI surgeon based in South Tyneside and Sunderland NHS Foundation Trust. I will be talking about the One-Anastomosis Gastric Bypass or OAGB. OAGB stands for One-Anastomosis Gastric Bypass, also known as mini gastric bypass or a loop gastric bypass. It is a type of weight loss surgery that creates a long, narrow stomach pouch and connects it to the small bowel with just one join. This affects both how much you can eat and how your body absorbs calories and nutrients. It is not a lesser operation despite being called a mini bypass. It is powerful and effective. Compared with the Roux gastric bypass or RYGB, the One-Anastomosis Gastric Bypass has one join instead of two. The surgery is usually slightly shorter and it produces greater malabsorption, meaning that supplements must be taken for life. The reflux risk can be slightly higher than a Roux bypass, but follow-up tests and long-term monitoring remain the same. The OAGB works in 3 main ways. The smaller stomach means less food can fit in. It can also cause changes to hunger hormones. It causes reduced absorption of calories because 150 centimetres of the intestine is bypassed to make the join. Patients may see the same amount of weight loss as a Roux gastric bypass and sometimes greater in the first 12 to 18 months. Improvement or reversal of type 2 diabetes is also another benefit. There is also better control of blood pressure and cholesterol. As with all bariatric surgery, there are risks, which may include internal bleeding, infection, anastomotic leak, which is a leak from the join, bile reflux in around 9 to 10 out of every 100 patients, and ulcers at the join. There is also a risk of damage to surrounding structures, which is rare. Nutritional deficiencies if supplements are missed, and dumping syndrome if sugary foods are eaten quickly can also happen. This is why yearly blood tests and lifelong vitamin and mineral supplementation are essential for life. It is important to note that ulcers are more common in smokers, so we would advise you to stop smoking and vaping. Whether the One-Anastomosis Gastric Bypass is the right procedure will depend on your medical history, reflux symptoms, BMI, medications, eating behaviours, and sometimes your endoscopy results. Your surgeon will help determine which procedure is likely to be the safest and most effective for you, but it is a shared decision between you and your surgeon.
So a gastric balloon is a very safe and relatively easy to perform bariatric procedure that helps patients lose weight. It's the only procedure that's performed solely with an endoscope, and it's the only procedure that's regarded as a temporary intervention. The procedure involves a camera test placed through the mouth, and at the time of the camera test, once we're happy that the stomach is healthy, we will then ask the patient to swallow a balloon which is attached to a long, thin, narrow catheter. Once the balloon is successfully placed within the stomach, We can inflate the balloon with 500 mils of fluid, and the balloon is then left behind in the stomach. The effect of the balloon helps people reduce their portion sizes by creating a feeling of fullness after eating, and if used in combination with diet and lifestyle changes, it will help patients lose weight. The amount of weight loss is variable, but it's somewhere between 10 and 15 kilograms, but that's very variable depending on how well you work with the balloon. And the balloon helps people lose weight, and it's a low-risk procedure that doesn't involve operating on the abdomen, so it can be performed in situations where entry into the abdomen can be quite challenging, for example, significant adhesions or abdominal wall hernias. It can be used as a bridging procedure to help people lose weight who are very heavy in order to get their weight down to a safe level for us to be able to perform a more definitive procedure. And in some cases it can be used as a procedure to help people lose weight prior to other types of operation, such as incisional hernia repairs. The balloons can stay up to a year, but what we see is that the weight loss is greatest during the first 2 months. And then there's probably a honeymoon period for a couple of months while the dietary changes are embedded. And between 4 and 6 months, most patients don't lose any more weight. And between 6 and 12 months, the aim really is not to regain any of the weight that you've already lost. Somewhere between 6 and 12 months is normally when we decide to take the balloon out because most of the benefits have been achieved, but it can stay for up to 12 months. So the balloon is normally a well-tolerated procedure. It's normally very safe to insert the balloon, but the problems that result from the balloon tend to be related to the balloon causing nausea, vomiting, or irritation of the stomach. Occasionally it can't be tolerated and needs to be removed early. Occasionally it can cause irritation in the stomach, resulting in heartburn, gastritis and ulcers. The worst case scenarios result in gastric perforation that can require an emergency procedure, and there have been extremely rare cases of the balloon spontaneously inflating or causing pancreatitis, which are both serious consequences. Most balloons are regarded as being a very safe procedure, but the risks tend to relate to issues tolerating the balloon in the longer term, and we need to monitor that carefully to make sure that you don't become dehydrated or have persisting symptoms that we can normally treat.
Hello, my name is Dr. Fiona Macon and I'm one of the anaesthetic consultants at Sunderland Royal Hospital. My job involves the anaesthetic side of your bariatric surgery. My aim is to help you feel informed, prepared and reassured about what will happen before, during and after your operation. I will cover pre-operative assessment and optimisation, how anaesthesia is delivered safely in bariatric surgery and what to expect on your day of surgery. Before your surgery, you will attend a pre-operative assessment appointment. This is a key part of your preparation and helps us plan the safest anaesthetic and surgical care for you. You will meet specialist nurses who will ask about your medical conditions, previous operations, medication, allergies, and any anaesthetic problems in the past. Most patients will need routine tests, such as blood tests, ECGs, blood pressure checks, and in some cases, heart or lung tests arranged with specialist teams. A dietitian will talk to you about your liver shrinkage diet. This helps reduce the size of your liver, making your surgery safer and easier. We will support you to become as fit as possible before your operation. This may include improving blood pressure control, improving diabetic control, stopping smoking at least 4 to 6 weeks before surgery, advice on increasing daily activity, and stopping certain medications temporarily. If you use CPAP for obstructive sleep apnea, please continue using it and bring your machine with you on the day of surgery. You will also have time to ask questions, discuss risks and benefits, and confirm your consent for surgery. On the day of your operation, an anaesthetist experienced in bariatric surgery will look after you. Your safety is our highest priority. Before you enter theatre, the whole team carries out safety checks, including identity checks, confirmation of allergies, reviewing your airway plan, ensuring your monitoring and equipment are appropriate for bariatric surgery. During your surgery, the anaesthetist will continuously monitor you. This includes heart rate, blood pressure, oxygen levels, temperature and depth of anaesthesia monitoring. Because bariatric patients may have a more difficult airway, we may use specialised equipment and have you positioned on the trolley in a ramp position to keep your airway safe. Whilst you're anaesthetised, we support your breathing with a ventilator, ensuring good oxygenation throughout surgery. We carefully plan your pain relief to reduce the need for strong opioids. Most patients receive local anaesthetic into their wounds, paracetamol and anti-sickness medication. You will receive blood thinners afterwards to reduce the risk of blood clots. You will arrive at the hospital's day of surgery admissions unit, DOSA, where a nurse will welcome you, check your details and measure your vital signs. You will meet your anaesthetist and the surgical team. They will go through the plan with you, confirm your consent, and answer any last questions you may have. When it is time for your operation, you will walk or be taken to the theatre area. The team will help you onto the operating table and position you comfortably and safely. Your anaesthetist and their assistant, an OGP, will attach monitoring and give you oxygen to breathe and medication through a cannula to send you to sleep. Most patients fall asleep gently within seconds. During your surgery, you will be asleep the whole time and closely monitored by the anaesthetic team. After surgery, you will wake up in the recovery ward. Nurses will monitor your breathing, comfort and pain levels. You may have an oxygen mask and a drip. Once you are stable, you will return to the ward. When on the ward, you will be encouraged to sit out of bed and walk early, usually the same day or the next morning. If you use a CPAP machine, you'll be asked to use it. This all helps to prevent chest complications and blood clots. Most patients go home 1 to 2 days after surgery, and you will receive written instructions on medication, wound care, diet, and follow-up appointments.